Welcome to PRISM Rounds, the audio journal club for busy ICU, ED, pulmonary, critical care, and sleep medicine teams. I'm glad you're here. In each episode, we take one important study and work through the clinical question, design, key results, limitations, and bedside relevance, making new evidence easier to understand and apply in everyday practice. I originally started these episodes to support my own learning and now share them in the hope that they are useful to other clinicians and learners. This podcast is for educational purposes only and is not medical advice. Clinical decisions should always be made in the context of the individual patient and treating team. If you enjoy the episode, please like, follow, or subscribe to PRISM Rounds on Apple Podcasts, Spotify, or wherever you listen to podcasts. And please share it with a colleague who might enjoy it too. Thanks for listening. This week, we discussed the Phase 3 SynAIRgy trial that evaluated whether AD109, an investigational bedtime combination of eroxybutynin and atomoxetine, could reduce obstructive sleep apnea severity, addressing an important unmet need for effective alternatives among patients who cannot tolerate or consistently use positive airway pressure therapy.
Can upper airway neuromuscular dysfunction, the actual root cause of obstructive sleep apnea, be successfully treated with just a simple bedtime pill?
Right, that's a dream, isn't it?
It really is, and that is exactly the question we are tackling today. Welcome to this deep dive on PRISM Rounds, Season 1, Episode 53. I'm just really thrilled you're joining us for this one.
Yeah, it's a phenomenal paper to dig into. I mean, honestly, reading through all this intricate sleep architecture data in the SynAIRgy trial.
Oh, the REM sleep disruption stuff.
Exactly, the REM disruption. It just made me acutely aware of my own sleep deprivation, honestly.
Right, I was going to say, you look a little tired.
Yeah, well, I'm coming off a rather brutal string of night shifts in the unit. So, the sheer physiological weight of fragmented non-restorative sleep is very front of mind for me right now.
I feel that. There is this very specific type of exhaustion that just sort of settles into your bones after a week of nights.
Yeah, that cognitive drag.
The cognitive drag, exactly. The sympathetic overdrive. I mean, it really gives you this profound, immediate empathy for the patients we evaluate in the sleep clinic every single day.
Oh, absolutely.
These are patients who spend decades dealing with fragmented sleep. They're just desperate for one single night of restorative rest.
Which is exactly why people get so hyped about a pill for OSA.
Right. The sheer desperation is why the prospect of pharmacological intervention generates such immense anticipation for us and for you, the listener. So today we are dissecting the Phase 3 SynAIRgy trial.
And just to jump in before we get completely lost in the mechanism of action or, the hierarchical statistical testing.
Which we will get to, I promise.
We definitely will. But we need to establish the clinical reality first. So I think we should just give the bottom line up front on this investigational combination, AD109.
Please, ground us in the reality, not just the hype.
Okay, so the bottom line on AD109 is, well, the drug did technically work. I mean, it's successfully improved the apnea-hypopnea index, the AHI, and improved objective measures of oxygenation.
Okay.
But the placebo-adjusted AHI reduction was ultimately just 4 events per hour.
Wow, just 4.
Just 4. And crucially, when you look beyond the monitor and actually evaluate the patient, their daily symptoms of fatigue did not significantly improve overall.
Which is the whole point of treating them, right?
Exactly. And to compound that lack of subjective benefit, roughly 1 in 5 participants stopped the treatment completely due to adverse effects.
1 in 5. That's huge.
It is. So the physiological proof of concept is definitely there, but the clinical utility for the average patient is highly, highly constrained right now.
Which honestly makes this the perfect moment to just quickly reaffirm the gold standard.
Always a good idea.
Right. Continuous positive airway pressure CPAP remains the single most effective, rigorously established therapy for obstructive sleep apnea. That is, of course, when used consistently.
Yeah, adherence is everything.
It really is. As a pulmonary and sleep physician, I spend my days explaining this mechanical reality to patients. OSA is, at its core, a mechanical obstruction. So CPAP provides a pneumatic splint.
It's physical physics.
Exactly. It creates a column of air that physically stents the pharyngeal tissues open. And the reality is no pill can replicate the sheer definitive physics of positive airway pressure.
No, I mean, the tendency in clinical medicine is always to view any novel pharmacological intervention as like a direct successor to mechanical therapy.
Right, because a pill just seems easier.
Right, exactly. But framing AD109 as a replacement for the CPAP mask is a fundamental misreading of what it can actually do.
It's an investigational alternative. It is strictly for a specific subset of patients.
Right.
Like when a patient struggles with CPAP, say they complain of claustrophobia or aerophagia or mask leaks, our first clinical reflex cannot be to just abandon the pneumatic splint and hand them a pill.
You have to optimize first.
Yes, we have to exhaust our technical and behavioral repertoire. That means, dedicating real time to meticulous mask fitting.
Adjusting humidification.
Exactly, optimizing heated humidification to prevent that mucosal drying and rebound congestion. We need to utilize expiratory pressure relief to make exhalation feel more natural. And, of course, sustained coaching.
Yeah, the behavioral aspect is huge.
It is the bedrock of sleep medicine. So we only really begin looking for pharmacological alternatives because there is this distinct cohort of patients who, despite all that aggressive multidisciplinary support, they simply cannot or will not tolerate CPAP.
And that unmet need is staggering. I mean, there are so many of those patients out there.
Millions. And that clinical void is what brings us to the underlying mechanism of this new oral combination. Because if we are trying to fix a mechanical problem with a systemic drug, how is AD109 actually designed to target that neuromuscular root cause?
Well, to understand the mechanism, we really have to isolate the exact moment of physiological failure in sleep apnea.
Okay, break it down for us.
So during normal wakefulness, your upper airway dilator muscles, predominantly the genioglossus and the tongue, they maintain this robust baseline tone.
Right, to keep the airway open.
Right, to keep the pharyngeal space patent against the negative pressure of inspiration. But when a patient transitions into sleep, and particularly into REM sleep, the brain actively suppresses that muscle tone.
Normal physiology so far.
Exactly.
Right.
In a healthy airway, the remaining tone is fine. It's sufficient. But in an anatomically vulnerable airway, this sleep-induced atonia basically precipitates the collapse.
So the airway just folds in on itself?
Yep. So AB109 is a fixed-dose oral combination taken once nightly at bedtime, and it's designed to artificially sustain that dilator muscle tone, despite the brain signals telling it to relax.
I often visualize the upper airway like a heavy canvas tent pitched in a storm.
I like that analogy.
Yeah. So the genioglossus and the surrounding dilator muscles, they're the guy lines holding the tent structure taut. And the negative inspiratory pressure from your diaphragm, that's the wind actively trying to blow the tent down.
That's a great way to picture it.
Thanks. So when a patient enters sleep, the central nervous system basically cuts the tension on those guy lines.
Right, and the wind wins.
The wind wins, the tent collapses. So to keep it standing, we have to manipulate the neurochemistry dictating that tension.
So what's the first component of this combo doing? The atomoxetine.
Okay, so atomoxetine is dosed at 75 milligrams here. It's a selective norepinephrine reuptake inhibitor.
Well-known mechanism.
Very well known. So by blocking the presynaptic reuptake transporter, atomoxetine significantly increases the concentration of norepinephrine in the synaptic cleft within the central nervous system.
Okay, so more norepinephrine hanging around.
Exactly. And when we localize this effect to the brainstem, this augmented noradrenergic drive heavily stimulates the hypoglossal motor nucleus.
Which is cranial nerve 12.
Cranial nerve 12, right. And that's the direct motor pathway to the genioglossus muscle of the tongue.
So it's basically a direct wire to those guy lines. Precisely. By pharmacologically flooding that nucleus with norepinephrine, atomoxetine artificially cranks up the neural drive to those airway dilators. It tightens the guy lines on your tent, even as the patient descends into sleep.
I mean, the physiological paradox there is just fascinating to me. You are taking a potent sympathetic neurotransmitter, literally the chemical mediator of vigilance and wakefulness, and you're deploying it directly into the brainstem at the exact moment the patient is trying to go to sleep.
It sounds counterintuitive, but it works on the muscle tone.
But atomoxetine alone isn't enough, right? That's why there's a second component.
Right, it's insufficient on its own, because that noradrenergic stimulation from the atomoxetine, it hits this wall of fierce physiological resistance when the patient transitions into REM sleep.
Because of the acetylcholine.
Yes. During REM, the brain actively releases acetylcholine. This binds to muscarinic receptors on the motor neurons, strongly driving that characteristic muscle atonia of dreaming sleep, to stop us from acting out our dreams.
Right, normal REM atonia.
Yeah. And you can't simply overpower that atonia signal with just norepinephrine. You have to block the atonia signal itself.
Ah, so that's where the second drug comes in.
Exactly. That is the role of the second component, eroxybutynin, which is dosed at 2.5 milligrams. It's a novel antimuscarinic agent.
So it blocks those muscarinic receptors.
Right. By binding to and blocking those specific receptors, it intercepts the cholinergic signal that is demanding that muscle relaxation.
So going back to the tense, atomoxetine is actively winching the guy lines tighter with norepinephrine, while the eroxabutynin is basically building a windbreak to stop the sleep-induced atonia from blowing the whole thing over.
That is exactly it. It's a dual-action approach.
And together they create the SynAIRgy, which elegantly provides the name for the SynAIRgy trial.
Very clever branding by the researchers there.
Seriously. And it's all focused on preserving that pharyngeal muscle tone. But, the timeline of this drug's development needs some context for our listener. We're analyzing a massive phase 3 trial today, but the researchers didn't just dream up this combination and instantly enroll over 600 patients, right?
No, definitely not. There was a precursor.
Yeah, so what was the earlier phase 2 data that justified this huge 26-week study?
So the immediate precursor to this was the phase 2b Mariposa trial. And Mariposa served as the critical proof of concept for this exact combination.
How long was that one?
It was short. They gave AD109 to adults with mild to severe OSA, but strictly for 4 weeks.
Just a month.
Just a month. But over that brief 28-day window, AD109 demonstrated a highly encouraging, statistically significant improvement in the AHI. And honestly, even some earlier pharmacokinetic studies suggested the drug could modulate the AHI from the very first dose.
I mean, a 4-week reduction in AHI is an impressive pharmacological achievement, but let's be real. Obstructive sleep apnea is a chronic, lifelong disease. A 1-month snapshot tells us virtually nothing about tachyphylaxis, like whether the receptors will downregulate and the drug will just stop working over time.
Or if the patients can even tolerate it.
Right. It tells us nothing about the chronic burden of taking a daily antimuscarinic and noradrenergic agent. The promise of Mariposa was basically just the entry ticket.
Right. It just opened the door.
Yeah, it necessitated the leap into this much larger, longer 26-week phase 3 SynAIRgy trial, because we needed to ascertain if the physiological effect is durable, and as you said, if a human body can actually tolerate this chemical manipulation over a clinically relevant time frame.
And the design of the SynAIRgy trial really reflects that rigorous requirement. It was a phase 3, randomized, double-blind, placebo-controlled study.
Huge undertaking.
Massive.
Yeah.
It sprawled across 69 distinct clinical centers in the United States and Canada.
Wow. And they ran it for 6 months.
Yes, 26 weeks. By extending it to 6 months, the investigators wanted to capture a much more realistic picture of long-term compliance and, durable physiological change.
Well, the methodology certainly sounds robust, but as we both know, a trial's utility is entirely dependent on its enrollment.
Always.
When you or I apply these findings in practice, we need to know precisely who was in the bed during the study. So who makes up this cohort of 646 adult participants?
So the inclusion criteria specifically targeted that unmet clinical need we were talking about earlier. They randomized patients with mild to severe OSA who had explicitly either failed or refused PAPE therapy.
Okay, so this is not a population of newly diagnosed treatment-naive patients who might actually do perfectly well on a CPAP machine.
No, not at all.
Yeah.
This cohort represents sort of the therapeutic dead end.
Right, the patients sitting in the clinic with an AHI of 25 who are just adamantly refusing to wear a mask.
Exactly. Now, the exclusion criteria are arguably more revealing than the inclusions here.
Really? How so?
Well, think about what we're giving them. When evaluating the safety profile of a dual-action neurochemical modulator,
Yeah.
you have to look at who the investigators actively protected from exposure.
Right, who did they keep out of the trial?
Right. Crucially, they excluded any patient with bothersome insomnia.
That makes perfect sense, given the atomoxetine.
And they also excluded patients with uncontrolled cardiovascular disease. Both of those exclusions are deeply intertwined with the pharmacological profile of atomoxetine.
Yeah, they're preemptively shielding the trial from the most predictable catastrophic side effects of systemic norepinephrine elevation.
Exactly. You don't want a sympathetic stimulant in a patient with uncontrolled AFib. They also excluded patients with narcolepsy, restless leg syndrome requiring medication, REM sleep behavior disorder, and significant craniofacial malformations.
That last one is interesting. By excluding craniofacial malformations, they're actively isolating the neuromuscular phenotype.
Right, because if it's purely structural.
Exactly. If a patient has severe micrognathia, like a significantly undersized jaw, their obstruction is structural. No amount of noradrenergic tone is going to magically move their mandible forward.
Yeah, you have to ensure the patients you're treating actually suffer from the neuromuscular laxity that the drug is designed to target.
So when we look at the baseline demographics of the patients who cleared all those hurdles, do we see a cohort that mirrors the reality of a busy sleep
We
practice?
really do. The demographics align remarkably well with broad epidemiological data on OSA.
Okay, give us the numbers.
So median age was 58 years old. The gender distribution was nearly perfectly balanced, with 49.3% women.
That's actually a fantastic achievement in a field that's historically been plagued by male-dominated trial cohorts.
Yeah, it's very refreshing. And the median body mass index was 32.4.
Okay, so a BMI of 32.4 places that median participant squarely in the Class I obesity category,
Right.
which is a vital detail for the listener to know. A BMI of 32 signifies a patient with significant adiposity, right? So likely including parapharyngeal fat deposition that physically narrows the airway.
Yeah, there's a physical crowding element.
But it is not the extreme Class 3 obesity where the sheer mechanical weight of the neck tissue would completely overwhelm any possible muscular compensation.
Right. A patient with a BMI of 45 would likely derive zero benefit from increased genial glossus tone. The compressive forces are just too massive.
Exactly. So what about their disease severity at baseline?
The median AHI was 19.6 events per hour.
So moderate OSA on average?
Yep. And the distribution was pretty broad. About 35% had mild OSA, 42% had moderate OSA, and 23% presented with severe OSA, meaning 30 or more events every single hour.
I am thoroughly impressed by that baseline demographic snapshot. I mean, a 58-year-old patient with a BMI of 32 and an AHI of roughly 20.
It's the classic patient.
It is the absolute archetype of the adult sleep clinic patient.
Yep.
We are not analyzing a highly curated, hyper-niche subpopulation here. This is the exact patient sitting on the exam table complaining about their mask.
The external validity is exceptionally strong here.
It really is. So with the clinical stage set, the whole analysis really hinges on the primary endpoint. At week 26, how effectively did this neurochemical manipulation actually alter their respiratory physiology?
So the primary endpoint was the absolute change in the apnea-hypopnea index from baseline to the end of that 6-month period. For the patients in the AD109 group, the AHI decreased by an average of 3.3 events per hour.
Okay, 3.3. And the placebo group?
In contrast, the placebo group actually experienced a slight worsening of their disease. Their AHI increased by 0.7 events per hour.
Interesting. So subtracting the placebo drift from the active drug effect gives us the true magnitude of the intervention.
Correct. The placebo-adjusted estimated mean treatment difference comes out to minus 4.0 events per hour.
Okay, -4.
And the 95% confidence interval for that difference ranged from minus 6.4 to minus 1.6, with a p-value of 0.001. So this reduction is statistically highly significant. The drug unequivocally altered the physiology.
Right. And this is exactly where we, and you as the listener, must exercise immense caution when interpreting the published data.
Oh, especially the abstract.
Yes, particularly how these results are framed in the abstract. Because the authors highlight that this difference represents a model-estimated 44.1% geometric mean reduction in AHI from baseline for the drug group compared to just a 17.6% reduction for the placebo group.
The relative risk reduction.
Right, and a 44% reduction sounds revolutionary. If I'm skimming the literature between patients, seeing a drug cut sleep apnea by nearly half seems like a complete paradigm shift.
But it's not.
No.
Okay.
So explain to the listener why anchoring our clinical understanding to that 44% relative risk reduction is fundamentally misleading here.
Well, relying on the geometric mean relative reduction completely obscures the clinical reality of the absolute numbers. The geometric mean is heavily influenced by lower baseline values, and it can be skewed by massive percentage drops and a very small number of super responders.
Right, which pulls the overall percentage down dramatically.
Exactly. We really have to look at the absolute clinical burden that is still remaining on the patient. Let's take our median patient from the trial, the one starting with an AHI of roughly 20 events per hour.
Okay.
If we apply the average absolute reduction of 4, their AHI drops from 20 to 16. Yes, they have experienced a highly statistically significant pharmacological effect, but clinically.
Clinically, an AHI of 16 means their upper airway is still collapsing.
Exactly. Their sympathetic nervous system is still surging, and their oxygen is desaturating 16 times every single hour they are asleep.
The physiological insult is still profound. They are literally still suffocating once every 4 minutes.
Right. And even if we generously apply that 44% relative reduction figure to that median AHI of 20, they land at roughly 11 events per hour.
So they've transitioned from moderate OSA into mild OSA.
Yes. But mild OSA is still a pathological state. The absolute difference of 4 fewer breathing interruptions per hour provides the vital, sobering context that the abstract's percentage conceals.
So the trial proves beyond a doubt that the neuromuscular mechanism works.
Yes, it works.
But the clinical magnitude of that mechanism, when averaged out across the entire population, is undeniably modest.
The mechanism is valid, but the magnitude is definitely muted.
But the AHI is merely a blunt counting metric. It just tallies the number of discrete respiratory events. It tells us virtually nothing about the actual physiological depth of those events.
That's a great point.
Right. To truly assess the cardiovascular stress imposed by the disease, we have to look at the oxygenation data. How did the secondary endpoints evaluate the hypoxic burden?
So the first secondary endpoint looked at the oxygen desaturation index, the ODI, which measures the frequency of significant blood oxygen drops per hour. The ODI improved by 4.5 events per hour in the AD109 group compared to placebo.
So it mirrored the AHI drop pretty closely.
Perfectly, yeah. Again, the finding is statistically significant, but clinically modest.
But I am honestly far more compelled by the concept of hypoxic burden than just the raw ODI.
Oh, absolutely.
Because the ODI is just another counting metric. Hypoxic burden measures the area under the curve. It integrates not just the frequency of the oxygen drops, but the severe depth and the prolonged duration of the desaturations.
It gives you the total physiological cost.
Exactly. I mean, a patient who drops to 89% for 5 seconds has the exact same ODI as a patient who plummets to 75% for 40 seconds.
But their risk profile is wildly different.
Completely different. Hypoxic burden captures that disparity, and it correlates far more strongly with the long-term risk of strokes, arrhythmias, and heart failure than an AHI ever will.
So, did the drug alter the actual burden of hypoxia?
Well, the data on hypoxic burden is arguably the most physiologically impressive aspect of the entire trial.
Okay.
And this is a big but, it is heavily encumbered by the statistical methodology.
Let me guess, hierarchical testing.
You got it. So the hypoxic burden fell by a staggering 44.7% in the AD109 group compared to a mere 8.5% reduction in the placebo group.
Wow, 44.7%. That is a massive drop. It is. However, from a rigorous statistical standpoint, this massive divergence is only considered, quote, nominally significant.
I often find the rigidity of trial statistics immensely frustrating from a clinical perspective.
It can be maddening.
If you have a nearly 45% reduction in the exact physiological parameter that damages the endothelium and triggers arrhythmias, why on earth is it relegated to being merely nominally significant?
Because of the hierarchical statistical testing. It's a necessary safeguard against type I errors or false positives when you're analyzing multiple secondary endpoints.
Right, to stop researchers from just fishing for positive results.
Exactly. Think of hierarchical testing like a sequential series of locked blast doors. You must successfully unlock door number 1, which is achieving statistical significance on your primary endpoint, before you are even permitted to attempt the lock on door number 2.
Okay, makes sense. So what happened in SynAIRgy?
In SynAIRgy, the statistical testing sequence was predefined. They passed the primary AHI gate, no problem. But further down the sequence, they hit the endpoint for patient-reported fatigue. And the fatigue endpoint failed to reach statistical significance. Because that specific door jammed, the formal statistical testing was mandated to stop completely.
So every single endpoint positioned behind fatigue in that predefined hierarchy is just out of luck.
Exactly. Including the profoundly impressive hypoxic burden data. It is permanently locked out of formal statistical validation. The researchers can report the percentages, but they cannot definitively claim the drug improved hypoxic burden without asterisking it as an exploratory finding.
It is a harsh reality of rigorous trial design.
Very harsh.
But it's the only way to prevent p-value dredging. So the failure of the fatigue endpoint halted the formal analysis. But before we dig into that subjective symptom failure, I want to quickly address the danger of relying purely on these population averages.
Right, the average can hide the extremes.
Exactly. An average reduction of 4 AHI events per hour paints a picture of a universally mediocre drug. But pharmacological averages routinely obscure extreme individual variances. Did the trial data reveal any subset of patients who experienced, a profound outsized benefit?
Yes. The responder analysis completely shatters that narrative of uniform mediocrity. The investigators looked at the percentage of patients who achieved an AHI below 5 events per hour.
Which is the clinical threshold for complete disease resolution, normal sleep.
Exactly. In the AD109 group, 17.6% of the participants drove their AHI below 5.
Almost 18%.
Yep. And in the placebo group, only 9.3% achieved that threshold.
That is wild. Nearly 1 in 5 patients taking this dual-action pill essentially experienced a pharmacological cure for their sleep apnea. Their AHI normalized.
It's a staggering realization when you contrast it with the average drop of 4.
Right. While the average benefit across the 646 participants was meager, there is clearly this distinct, currently invisible subpopulation within that cohort. Their unique airway anatomy and specific neuromuscular deficit must perfectly align with the pharmacological action of atomoxetine and eroxybutynin.
They respond beautifully to it.
They really do. The obvious challenge is that right now we have absolutely no way of identifying who those super responders are before we prescribe the drug.
Identifying them is absolutely the future of the field. But for the present moment, we have to evaluate the drug based on its effect on the entire cohort.
Sure.
And that really brings us to the most clinically relevant question of this entire deep dive. We can sit here and debate the intricacies of hypoxic burden and geometric means indefinitely.
But the patient doesn't care about that.
No. The patient sitting in the exam room only cares about one metric. Do they feel better when they wake up?
Yeah.
Did this objective physiological improvement actually translate into a subjective alleviation of their exhaustion?
This is the ultimate crucible for any sleep therapeutic. If a drug perfectly normalizes the polysomnogram monitor, but the patient remains incapacitated by brain fog and hypersomnolence, the clinical utility is essentially zero.
Exactly.
So, to measure the subjective lived experience, the trial utilized the PROMIS scores, right?
Yes. The Patient-Reported Outcomes Measurement Information System.
Which is a highly validated, deeply rigorous tool. It utilizes complex item response theory to translate these sort of nebulous subjective feelings into standardized, quantifiable T-scores.
It's the best we have for this.
So when the patients taking AD109 woke up, did their PROMIS scores reflect a meaningful reduction in their daily fatigue?
The objective data dictates a definitive no.
Ouch.
Let's analyze the PROMIS fatigue metric. The patients randomized to AD109 experienced an improvement of 7.4 points on the fatigue scale.
Okay, so they did feel a little better.
They did. However, the patients taking the inert placebo pill experienced a remarkably similar improvement of 6.2 points.
Wow. The magnitude of the placebo effect in sleep medicine trials never ceases to astound me.
It's massive.
It is. Just the simple act of enrolling in a trial, completing sleep diaries, interacting with empathetic researchers, and taking a pill, it inherently makes patients feel more rested, entirely independent of the pharmacology.
The placebo effect is a massive confounder here. When you isolate the active drug effect by subtracting the placebo improvement, the true between-group difference in fatigue reduction was a negligible 1.2 points.
And the p-value?
P-value for that minuscule difference landed at 0.059.
A p-value of 0.059, the agonizing near miss.
Yep, it fell just short of the 0.015 threshold for statistical significance, which is precisely what jammed the blast doors in the hierarchical testing we discussed earlier.
And what about the other subjective metric?
The failure was uniform. The PROMIS sleep impairment scores mirrored the fatigue data perfectly, showing no meaningful, statistically significant divergence between the drug and the placebo.
So, the synthesis of this efficacy data presents a really profound clinical discordance. The SynAIRgy trial definitively proved that manipulating the hypoglossal motor nucleus with this drug alters the underlying physiology. The AHI dropped, the oxygenation improved.
Right.
But the trial completely failed to establish that this physiological modulation translates into any perceptible symptomatic relief for the average patient.
It felt exactly the same.
Furthermore, because the trial was capped at 6 months, it's entirely inadequate to answer the most critical longitudinal question. Does a modest 4-event drop in AHI actually reduce the incidence of catastrophic cardiovascular events like strokes and MIs over a 10-year horizon?
We simply do not know.
We don't. We are left with a drug that marginally improves the monitor while leaving the patient feeling exactly the same. And in medicine, when the efficacy is marginal, the entire viability of the intervention rests on its tolerability.
That is the crux of the issue.
So what is the physiological cost of taking this combination every single night?
The safety profile of AD109 requires really meticulous scrutiny, especially considering this is a medication intended for chronic, likely lifelong daily ingestion. The adverse event signal in this trial is impossible to ignore.
What were the numbers?
Adverse events were reported by an overwhelming 70.8% of the patients in the AD109 group.
Wait, over 70% of the treatment arm experienced a side effect?
Yes.
That is a massive physiological toll. How does that compare to the background noise of the placebo group?
The placebo group reported an adverse event rate of 46.7%.
Still high, but the delta there is undeniable. That represents a severe burden of drug-induced toxicity.
It really does.
We have to unpack the specific nature of these adverse events because they aren't just random. They trace perfectly and predictably back to that aggressive neurochemical manipulation we detailed in the pharmacology section.
Yep, the mechanism dictates the side effects.
So let's start with the antimuscarinic blockade. What was the most prominent consequence of adding eroxybutynin?
By a very wide margin, the most prevalent side effect was dry mouth, which afflicted 35.4% of the patients taking AD109.
More than a third of the cohort.
Yeah.
And, while dry mouth might sound like a trivial inconvenience to some in the context of chronic daily dosing, it is a devastating side effect.
It absolutely is.
Eroxybutynin blocks muscarinic receptors. Those receptors govern the parasympathetic nervous system, responsible for the classic rest and digest functions, salivation, lacrimation, digestion. When you induce pharmacological xerostomia every single night, you aren't just making the patient uncomfortable.
You're risking their teeth.
Exactly. Saliva is essential for maintaining the pH of the oral cavity and neutralizing bacterial acids. Chronic severe dry mouth inevitably leads to rampant dental caries, periodontal disease, and severe oral infections. Asking a patient to risk their dentition for a 4-event drop in their AHI is an incredibly difficult clinical proposition.
It's a hard sell.
Very hard. What was the next major consequence of the drug?
The second most common side effect was insomnia, reported by 20.6% of the AD109 group.
The profound, inescapable irony of this mechanism. You are prescribing a pill to treat a sleep disorder, and you directly induce insomnia in 1 out of every 5 patients who take it.
It's ironic, but physiologically, it is the only logical outcome.
Right. Atomoxetine is flooding the central nervous system with norepinephrine. Norepinephrine is the primary chemical mediator of the sympathetic nervous system, the fight-or-flight cascade.
It actively drives hyperarousal.
Exactly. Vigilance and anxiety. If you blast the brainstem with a noradrenergic stimulant to stiffen the tongue, you are simultaneously broadcasting a massive systemic stay-awake signal to the entire cortex.
Honestly, the fact that only 20% reported insomnia is almost surprising to me.
Right. And this noradrenergic reality is exactly why the investigators were forced to exclude patients with pre-existing bothersome insomnia from the trial in the first place. The drug would have exacerbated their condition immensely.
Definitely. And the pharmacological cascade continues down the list of side effects. Nausea was reported by 11.4% of the treatment group.
Anticholinergic GI slowing.
Right. Furthermore, urinary hesitation occurred in 8.9% of the patients.
And the urinary hesitation is a textbook antimuscarinic effect. Muscarinic receptors are essential for the normal contraction of the detrusor muscle in the bladder wall.
Right. If you block them, the bladder can't squeeze.
Exactly. When eroxybutynin blocks those receptors, the bladder cannot effectively empty. And remember, we are looking at a trial population with a median age of 58. That inherently includes a large cohort of men with varying degrees of benign prostatic hyperplasia.
Giving a potent antimuscarinic agent at bedtime to a 60-year-old man with an enlarged prostate is a guaranteed recipe for acute urinary retention.
It really is. So when you synthesize the severe dry mouth, the chemically induced insomnia, the nausea, and the inability to void, how does the average patient respond? What actually happens to the compliance rate?
Well, the compliance data reflects the severity of that side effect profile perfectly. Because of these cumulative everyday toxicities, 21.2% of the patients randomized to AD109 definitively discontinued the treatment.
Over 21%.
Yeah. More than 1 in 5 highly motivated trial participants concluded that the daily reality of taking the medication was entirely worse than the baseline symptoms of their sleep apnea.
Wow. And what was the dropout for placebo?
In stark contrast, the discontinuation rate in the placebo group was merely 3.1%.
A 21% dropout rate within the heavily monitored, deeply supportive environment of a phase 3 clinical trial is a massive red flag.
Huge red flag.
Because clinical trial participants are intrinsically more compliant than the general population. They have study coordinators calling them, checking on them. If 1 in 5 trial participants quits because they cannot tolerate the dry mouth and the insomnia, the real-world discontinuation rate in a standard sleep clinic will likely be vastly higher.
I have to objectively note, though, that the trial reported no serious treatment-related adverse events.
Okay, so no acute emergencies.
Right. The drug did not cause acute life-threatening emergencies, but As that discontinuation data proves, everyday tolerability is an immense, perhaps insurmountable hurdle for this specific compound for the average patient.
Yeah, the subjective side effects drove the discontinuation. But there are objective physiological alterations induced by this drug that I find deeply, deeply concerning.
You're talking about the sleep architecture.
Yes, the alteration of sleep architecture itself is staggering. When you look at the polysomnography data, what actually happened to the patient's REM sleep?
The suppression of REM sleep was dramatic. At baseline, the patients spent 15.6% of their night in REM sleep.
Okay, about normal.
But while taking AD109, that percentage plummeted to a mere 7.2%.
The drug basically eradicated more than half of their REM sleep.
It did.
And REM sleep is not a disposable luxury. It is the phase of sleep where we engage in our most vivid dreaming. It is physiologically essential for emotional regulation, the consolidation of complex memories, and the clearing of metabolic waste from the brain.
It's vital.
When you pharmacologically have a patient's REM sleep every single night for 6 months, you are inducing a profound alteration to their fundamental neurobiology. You really have to anticipate long-term consequences regarding their mood stability and their cognitive processing.
The suppression is an unavoidable consequence of that dual mechanism, though.
Right, because the transition into REM is driven by acetylcholine.
Exactly. Ascending cholinergic pathways, specifically acetylcholine binding to muscarinic receptors, drive us into REM. Eroxabutynin directly antagonizes those exact receptors. It actively prevents the neurochemical initiation of REM.
And the atomoxetine.
Simultaneously, the massive influx of norepinephrine from the atomoxetine actively suppresses REM sleep pathways. Both halves of AD109 are chemically engineered to obliterate rapid eye movement sleep.
Which introduces a massive, deeply troubling methodological confounder into the entire trial.
How so?
While we know definitively that sleep apnea events are universally worse, far more frequent, and vastly longer during REM sleep, because the natural muscle atonia is at its absolute deepest.
Right. REM sleep is when the airway is most vulnerable.
So if AD109 fundamentally prevents the patient from entering REM sleep, is the drug actually improving the pharyngeal mechanics? Or is it merely preventing the patient from entering the most dangerous phase of sleep? Are we effectively treating the AHI, or are we just sweeping the severe apneas under the rug by eliminating the REM stage where they occur?
Right. And that is the single most vital methodological question the researchers had to address to prove their drug wasn't just a REM-suppressing artifact.
Did they address it?
They did. To resolve this, they utilized a complex statistical adjustment model. They recalculated the primary AHI outcomes, specifically controlling for both the massive reduction in REM sleep time and the minor fluctuations in patient body weight.
And what did the model show?
Crucially, this rigorous adjustment did not eliminate the drug's efficacy. The reduction in AHI remained statistically significant, even when the loss of REM was factored out.
Okay.
So this proves that AD109 is genuinely modulating the upper airway tone during non-REM sleep stages as well.
Okay, that statistical adjustment is a relief. It proves the neuromuscular stimulation actually works outside of REM. However, just because the AHI reduction isn't entirely an artifact doesn't exonerate the drug for me.
Fair enough.
Proving the math works does not make having a patient's REM sleep clinically acceptable. It remains a massive physiological compromise. And the sleep architecture wasn't the only system compromised. We also must discuss the cardiovascular data.
Right. The cardiovascular alterations were precisely what the mechanism predicted. Tachycardia, a sustained, elevated heart rate, was significantly more frequent in the patients taking AD109.
That's surprising.
No, it's the direct, unavoidable consequence of atomoxetine elevating systemic norepinephrine levels, which aggressively stimulates the beta-1 adrenergic receptors in the myocardium, driving up the chronotropy of the heart.
And this brings us right back to the exclusion criteria. This chemically induced tachycardia is exactly why the investigators barred anyone with uncontrolled cardiovascular disease from enrolling.
They had to.
If you have a patient with a vulnerable myocardium, perhaps ischemic heart disease, or a propensity for atrial fibrillation, prescribing a daily, nightly sympathetic stimulant is incredibly hazardous.
Especially long-term.
Exactly. The entire fundamental purpose of diagnosing and treating obstructive sleep apnea is to reduce the long-term risk of cardiovascular events caused by the sympathetic surges of suffocation. If the drug we use to fix the airway simultaneously drives a constant chemically induced tachycardia, we are just replacing one cardiovascular stressor with another.
And because this trial was strictly limited to 26 weeks, the long-term safety regarding major adverse cardiovascular events remains highly uncertain.
We do not know if elevating a patient's nightly heart rate for 5 years will ultimately cause more myocardial damage than a modest 4-event reduction in their AHI prevents.
We really don't.
Yeah.
And the uncertainty surrounding those long-term cardiovascular outcomes underscores the necessity of meticulously contextualizing this trial. When we evaluate any major clinical publication, we have to weigh the methodological strengths against the glaring limitations.
And crucially, we must transparently disclose the structural conflicts of interest.
Let's delineate the strengths first. The SynAIRgy study was highly ambitious. It was large. The baseline demographics were wonderfully representative of a real-world clinical population, and it adhered to rigorous, double-blind, placebo-controlled standards.
It asked a specific physiological question and answered it definitively. The drug works.
Right. But the limitations severely constrain the clinical applicability. A 21% dropout rate drastically limits the generalizability of the longitudinal data because the cohort inherently self-selects for the most tolerant patients.
And, as we just discussed, a 6-month window is woefully, dangerously inadequate to assess the true cardiovascular consequences of a medication intended for lifelong use.
Regarding structural transparency, we also must note the funding apparatus behind the trial. The SynAIRgy trial was entirely funded by Apnea, the pharmaceutical entity that is developing and patenting AD109.
The sponsor.
All right. Furthermore, an examination of the disclosure forms reveals that several key authors are direct employees of Apnea. One of the authors also holds specific patents for methods and compositions for treating sleep apnea, which are licensed directly to Apnea, a relationship from which they receive annual royalties.
You know, the reality of modern pharmaceutical development is that a massive Phase 3 trial spanning 69 centers costs tens of millions of dollars. Only an industry sponsor possesses the capital to actually execute it.
The authors have fully and appropriately disclosed these financial relationships in accordance with publication standards.
Yes, they have. However, as clinicians responsible for patient safety, we must evaluate industry-funded trials with significant internal financial ties through a lens of profound clinical skepticism. Our responsibility is solely to the patient, which requires us to parse the raw data and separate the statistical significance from the clinical relevance.
Absolutely.
So synthesizing this immense volume of data, pharmacology, and trial design, how do we crystallize this deep dive?
I believe we can distill the totality of the SynAIRgy trial into 3 distinct, indisputable takeaways.
Go for it.
First, the trial represents a massive physiological proof of concept. AD109 definitively improved the objective mechanics of obstructive sleep apnea. It successfully lowered the apnea-hypopnea index and improved the objective metrics of oxygenation, proving that manipulating the hypoglossal motor nucleus is a viable target.
Agreed. Second, we must decouple the mechanism from the magnitude. While the drug works, the absolute clinical benefit was highly modest, a reduction of only 4 respiratory events per hour. And most importantly, this minor physiological improvement was entirely clinically neutral when it came to the patient's lived experience. The subjective symptoms of fatigue and sleep impairment did not significantly improve.
And third, everyday tolerability stands as the central, likely insurmountable challenge for broad adoption of this drug. With over 70% of patients experiencing adverse events and a massive 21% discontinuation rate driven by severe dry mouth, chemically induced insomnia, and urinary retention, the physiological cost of taking this pill heavily outweighs the modest benefit for the average patient.
Which leads me to unequivocally reaffirm the standard of care. Continuous positive airway pressure remains the safest, most effective, and most firmly established therapy for obstructive sleep apnea.
Still the gold standard.
CPAP carries zero risk of systemic cardiovascular toxicity. If properly integrated with heated humidification, it does not cause severe xerostomia. And crucially, unlike AD109, CPAP does not destroy REM sleep. In fact, effective CPAP therapy routinely facilitates a massive restorative REM rebound.
That's true.
So, AD109 is a fascinating, elegant pharmacological experiment. Pending significantly more long-term safety data regarding the cardiovascular and cognitive impacts of REM suppression, it may eventually carve out a highly specific niche for the most desperate CPAP-intolerant patients. But it is not a paradigm shift. It will not dethrone the pneumatic splint.
I agree completely. Yet, the most compelling data point in the entire trial hints at where the paradigm might actually shift.
The super responders.
Exactly. That specific subset of patients, the 17.6% who achieved an AHI under 5, who are essentially pharmacologically cured by AD109, that forces us to look toward the future. The evolution of sleep medicine is not going to be defined by developing a single blunt instrument pill that we just blindly prescribe to everyone.
The future is precision phenotyping.
Precision phenotyping, because obstructive sleep apnea is not a monolithic disease. It's a heterogeneous collapse driven by varying endotypes, anatomical crowding, poor muscle responsiveness, a low arousal threshold, So the question to mull over is this: can we develop advanced, highly specific clinical tools, perhaps leveraging baseline polysomnography data, specific anatomical imaging, or even genetic markers to accurately identify those super responders in advance?
If we can precisely phenotype the patient in front of us and confirm their obstruction is driven purely by the specific neuromuscular deficit that atomoxetine and eroxabutynin target, we can ensure that this drug is only prescribed to the exact patients who will achieve that complete cure,
entirely avoiding the massive side effect burden for everyone else.
That is the exact question driving the next decade of sleep research. Precision medicine, targeted phenotyping, and matching the specific chemical intervention to the exact anatomical failure.
We aren't there yet.
No, we are clearly not there yet. But robust, complex trials like SynAIRgy, even with all their glaring caveats and side effects, are the necessary stepping stones building the path to that future.
Well said.
Thank you. And thank you for joining us for this extensive analysis. As a reminder, PRISM Rounds is an educational deep dive into medical literature designed for healthcare professionals. This discussion is for informational purposes only and does not constitute direct medical advice. Always consult the full peer-reviewed literature and utilize your own clinical judgment when evaluating therapeutics and managing patient care. We will see you on the next round.
Thanks for spending your time with PRISM Rounds. If this episode was useful, please like, follow, or subscribe, and share it with a colleague. Leave a comment with your bedside takeaway, a question, or a paper you'd like covered next. Your feedback helps shape future episodes. Thanks again for listening. Educational use only, not medical advice.